evening to all of you. As the president of the Shankar Netra Alumni Association, I have the greatest pleasure of welcoming all of you for this first Shankar Netralaya Alumni Connect Series webinar. As I told you, this webinar, we are planning to have it on the 2nd and 4th Sunday of every month between 8 and 9:30 p.m. IST. The main idea of this webinar is to connect all the SN alumni across the country. And each of these webinars will be like a potpourri, like what we are doing today. And every webinar will cover one subspecialty. For example, the next webinar we are planning to have on uvea, and subsequently on ocular trauma, then pediatric ophthalmology, cornea, something like that. The main thing is, I was discussing with Dr. Natarajan also, and Manoj, as well as Rajiv Raman and other people. As you know, Rajiv Raman is the secretary of the Shankar Netra Alumni Association. And we have also the very dynamic chairman scientific committee, Partha Pritham, who is also likely to join the webinar as very soon. The main thing is we have identified about 5-6 speakers, and they'll be presenting some interesting videos or cases, something like VAST, video assisted skill transfer. And these main people are all Shankar Netra alumni who are outside Shankar Netralaya. We want to give preference to people who are outside Shankar Netralaya, and so that and mainly the younger generation of the Shankar Netra alumni, and the panelists and the chairman will be the senior Shankar Netra alumni, like what we have today: Dr. Natarajan, Rajiv Raman, myself, and Mahesh Gopalakrishnan. So, with these few words, I welcome the Chairman, Dr. Natarajan, whom you all know doesn't require any introduction, is actually the main force behind the Shankar Netra alumni. He is now the patron. I've taken over from him as a president. And of course, our secretary, Dr. Rajiv Raman, who is very, very dynamic and who infuses a lot of ideas into a Shankar Netra Alumni Association. And of course, Dr. Mahesh Gopalakrishnan, the top guy in Giridhar Eye Institute in Kochi, who is also a Shankar Netra alumnus, a top vitreoretinal surgeon, and he'll be also chairing the session. And then we have the dynamic chairman scientific committee, Partha Pritham, as well. And Manoj Khatri doesn't require any introduction. He's one of the very, very dynamic, vitreoretinal surgeons of Chennai. And he was with me till recently. He's always with me. He's inside my heart, so he cannot go out anywhere. So Manoj Khatri will be moderating the whole session. And we have got, as Mahesh rightly said, we've got some fantastic speakers. All these speakers are they are quite young but very experienced in whatever they're going to talk today. And we'll have a very good discussion also. And hopefully, we should be able to finish the webinar within that stipulated time. We don't want to go beyond that time, because all of us have to celebrate the event. Not only that, we found out that all the webinars, if it's around 1 hour or 1 hour 15 minutes, people are there to stay on. Otherwise, if it goes beyond that, no, people leave the webinar and go off. So let us focus and let us talk to the point and have a good discussion and good exchange of ideas as well. And over to Dr. Natarajan for a few words, and then Rajiv Raman, and then Mahesh.
Thank you, Mohan. I think it's a wonderful idea. Only thing I will have a suggestion: out of 5 speakers, one can be from anywhere, as an alumni from anywhere in the world, so that you connect the whole world. You are nice enough to organize the SN alumni in AO, where we brought Tarun Sharma and many others who we met. So in every specialty, we have people practicing all over the world. All the 6 continents we have SN alumni. So one speaker can be, I know it will be a difficult timing for them, except Australia. Rest of the people can take part in, and the Australia people one day maybe you can do it for them separately. There are a few alumni in Australia. There are, I think, glaucoma and somebody from Retinal also. So I think it should be global, and definitely we have to show what we are as an SN alumni to the world. With this, I request Manoj to take over.
Thank you, Nati. And Rajiv, Secretary.
Yeah, sir, a great initiative, and definitely having these webinars will add value. Let it not be the routine webinars which we attend, which goes for hours.
Yes.
As Dr. Mohan Rajan rightly said, 1 hour we quickly finish, and at the end of that we gain some knowledge. We learn from each other. And as Mahesh rightly said, the speakers are all experts here, so we really don't need big panelists there. All of them, all of you can discuss. That's the way we all have been taught at Netralaya. Please, Mahesh, anything you'd like to add?
Mahesh?
No, I hope honored to be part of this panel, and I hope definitely I will learn something from the presenters. That is what I aim at. Thank you.
Sure.
Okay, over to Manoj then. Thank you, Mahesh, Rajiv, and Nati. And over to Manoj. Manoj,
Yes,
please
sir.
take over. Yeah.
Good evening and a very warm welcome to all of you for joining us on this first initiative of the Shankar Netralaya Alumni Association Connect series webinar. At the outset, let me wish all of you a very happy Diwali as well. And the main agenda also includes to get Shankar Netralaya Alumni Association person at the helm of All India Ophthalmic Society presidentship. So here we are, yeah, supporting and rooting for Dr. Mohan Rajan to vote for him for 2025 AIS election wholeheartedly with all our support. And we all owe this responsibility to ourselves to make him win the election. I will say hands down, and also, if possible, from all of us, pressure, maybe unopposed as well. So keep this in mind, and we will be all working towards it, sir, and we'll make sure that you come, on the winning side this time.
Thank you, Manoj, for that. Yes.
Yes, sir. It's a very important agenda for all of us. Entire Shankar Alumni Association owes you this, sir. So with this, let's start with the first talk of the evening, which will be by none other than a very dear friend, Dr. Abhishek Potpourri from Jaipur, and he will be sharing his surgical pulse with us. Over to you, Abhishek.
Yeah, thank you,
Abhishek.
Manoj. Yeah,
And, Abhishek, and I
Yes.
just wanted to tell, I saw Abhishek do live surgery for the MIOM conference in Dubai. So it was a proud privilege for our, as an SN alumni, to be there watching from the audience.
Excellent.
Thank you. Fantastic, Abhishek. Very
Thank you
good.
so much, sir. Thank you so much, sir. So today I'm basically I thank Manoj. He told me that in 5 minutes we have to present a surgical pearl or a peculiar situation, and this is a case I had operated recently. This is something this was presented at Retinal also. This is what we call as part of the cataract graveyard, that is the grave complications after cataract surgery, and that is globe perforation. Now, when a patient presents to you with this kind of image after cataract surgery, and if it has been a cataract surgery with no iris trauma or other possible sources, then you should be suspecting a globe perforation. And how do you go about handling it? So I'll just show you this particular case that came to us with minimal, visual gain. So when we looked in the inferior periphery, sometimes the blood has settled down a little bit. We saw a whitish kind of a lesion. This possibly could be the needle, track. So this is the surgery that we have started clearing the blood. And this is, once we've cleared the blood, this is what it looked like. So if you see carefully, as I'm progressing with the vitrectomy, you'll see carefully that there is the track where the needle has gone through. There's a macular hole, and there is a BRAO also. There is a branch retinal artery occlusion. So we have created the PVD. We have now trying to stain this with the brilliant blue dye. And once it is stained, I'll show you the exact picture. So this is the macular hole, and that is the large needle exit tract. This is the exit wound, and you can see the BRAO also. So all three pathologies in one go. So here, what our plan was that, of course, we have to laser and seal the perforation site. But for the macular hole, we thought of creating this is not an idiopathic macular hole. This is because of a mechanical trauma of the drug injected in the retina. This is kind of a blowout macular hole. So here we plan to inverted ILM flap. Now this is all friable retina given the fact that there is also a retinal artery occlusion that has happened. So I'm going ahead very carefully and picking up bits and pieces of the ILM, leaving them attached at the hole margin. My general tendency is to peel off all the ILM from the nasal side and leave the flat on the temporal side. And I'll show you in a minute why. And I usually don't do the stuffing technique and the multiple layer technique. I try to keep just a couple of layers, the minimum possible. This was another ERM that was removed, and there is subretinal hemorrhage also in that region, if you can see. That will make our job of the retinopexy a little tougher. So here we have cleared all the ILM from around the macular hole. And this is the area where I did it very gingerly because this is the area with the retinal thinning also. I'm just carrying forward the PVD induction pole, and now I'm carrying it to the periphery and then completing the vitrectomy. You can see the flap. The flap is hinged on the temporal margin of the macular hole. Now, if you see very carefully here, we see a glimpse in the video where there is hemorrhage. There was the entry wound. Now, after this, we go ahead and do a fluid air exchange, and you see why I keep the temporal flap, so that when I'm doing an FAE, with the force of the fluid, the flow of the fluid, the flap folds over the macular hole and closes the macular hole. So minimum manipulation is required. So I'm lasering the peripheral, the entry wound, and for the so the part which is away outside the arcades, I'm using 2 layers of laser spots. But for part basically where half a spot is inside the wound, I'm doing it from the inside and overlapping the edge of the wound, and one spot goes around and covers ahead of it. I'm using a reasonably heavy power here because I want to create a tight scar. Otherwise there is a possibility of a CNVM also arising later on from this area. So it's a tricky situation. Now once that is done, I just gently with very minimal manipulation, I have put the the flap at the macular hole, and this is the surgery done. Now this particular patient was one-eyed. The other eye was already lost to a RD long time back. So I'm putting in oil, but you could very well easily leave gas also. And this is the post-operative result. This is the macular hole that is closed with the ILM flap. You can see the RNFL thinning. That is because of the BRO. We were kind of expecting that. So thank you and wish you all a very happy Diwali. A short 5-minute video is what I was requested. This is what it is.
What is the post-op vision, Abhishek?
Post-op vision was 624, sir. 624 parts.
Brilliant, Abhishek.
Yeah.
Brilliant as usual. Aravind sir, any comments?
No, great case and nicely managed. I think though these are very challenging situations, luckily retina was not detached. Many times you have these multiple sieve, like when there is this perforation, multiple breaks, retina getting detached, then things become a little more, but I think you did a great job and he got a good vision. The only reason why that fibrosis, everything is formed because it's very near to the fovea, heavy burns, chance of later causing a ERM is definitely very high. And that's something you need to keep in mind. But I think the best way, another thing is if view is there, in his case, though, even there was a wet heme, but you were knowing that that was a whitish color lesion there. If view is there, sometimes you can only do a laser. If it is away from the fovea, you need not do a full vitreous surgery if you can manage. If there is a vitreous traction or a retinal pull there, definitely you need to go in. But in this case, there was vitreous hemorrhage, so definitely you need. These are not the cases where you should wait because that will definitely cause a detachment. Mahesh, anything you would like to add?
Yeah, actually, even if there is no macular hole and perforation is little away, it is better to remove the ILM because 4 or 5 cases where I have done, all of them developed ERM later in the follow-up time. So even if there is no macular hole, these sort of cases, probably chance of ERM formation is very high. So better to do ILM. That is one point. So nice case.
The
No,
soft,
Abhishek, I just wanted to know what is the axial length of this patient?
No, this was normal, sir. I mean, the IOL power was only 19.5. It was not a high myop case, sir.
What was the reason for the RD in the other eye?
The RD, that was a long time back. That was a bad pseudophakia, basically, sir. With vitreous coming in the wound, and it developed into RD, and the patient never got treated for that. So that was an inoperable RD. That was almost 6-7 years back.
Normal axial length.
Normal excellence. The IOL power that they had put, with the patient had come with the discharge summary with the biometry was only the IOL power was only 19.5.
9 point. Nati?
So this was
Yeah,
this center came to me from a center where the optometrist basically does the case selection, and the ophthalmologist just goes there and operates. The block is also given by the optometrist there, and probably the skill was deficient there, and they went through. I mean, this is the second case from the same center I got. So this time I actually called them up and told them, "Okay,
Maybe
please give
optometrist was giving the block.
optometrist give the block there."
That's a problem.
Abhishek, the soft tip cannula, what you used to stuff the eyelid, it was attached to flute needle or to a syringe?
A closed syringe. So if it is attached to the flute needle, there is a little bit of minimal residual suction still there, even when you've closed it. So that can sometimes pull off your flap. So it's always a closed syringe. It's 2cc closed syringe
I do the same way. So I just you're doing this with a syringe or with a flute needle. So I think
So only one point, Manoj. Manoj,
yes, sir.
can I, no. 1 point I want to make is I remember Dean Elliott, who's now the chairman of Mass Eye and Ear Infirmary, came to my clinic in '95, and actually that time anesthetist was, even now anesthetist gives the local, but nowadays the new team is there, so I make the ophthalmologist give. But that time the Dean Elliott he came to the OT and he asked the anesthetist, "Do you know the axial length of the eye?" Because he was about to give the local. He says, "I don't know." He says, "Better you know the axial length and then you take the needle." So I think it's that's a good question which Mohan asked. But I think here, since even optometrists is dealing with the axial thing, I think they should be probably given education, and I don't know how to do that because they are not referred directly. But I think one thing is these sort of videos should be presented in various places so that the anti-segment surgeon can see without telling them who's doing. I think this is total negligence, which the word negligence need not be there, but I think you have to educate them because poor guy goes for a cataract and comes and
Yeah.
The use of a subtenance block rather than a peribulbar is much safer and can go along.
Yeah, I know, but the problem here is the optometrist is doing, and the ophthalmologist who is running the center should be responsible and train the people. I mean, in government ophthalmic hospital, we had a OT technician giving, but I think they had experience and they knew that high myopia, even posterior cephaloma. I remember I always used to tell the anesthetist, "No, I will do it myself," because what is the harm in doing it? And you do the local, and then fellows also I don't trust in the beginning. I keep telling them, "Do you know the axial length and do you know what is the posterior part of the highly myopic eye and even a retinal detachment? Why should I have a perforation?" I mean, recently I had a patient where a retinal detachment, when the anesthetist was giving, perforated the thing, and I would repair it immediately, and already there was a detached eye. But the ERM formation is.
Your voice has gone. Voice has gone.
Sorry, no. I said the perforation makes traumatic PVR. So ILM peeling is important, and close follow-up, and in membrane forms, I think we should remove it.
No, I want to give a final message.
I also had a case like that.
Yeah.
Where I've seen the patient, beforehand, and another doctor had given the block. And when I went inside the vitreous cavity, I saw the vitreous hemorrhage. I said, "Come on, I've seen the 1 hour back. There was no vitreous hemorrhage, and suddenly, there is a subretinal hemorrhage and there is a vitreous hemorrhage." And like you said, exactly this is what happened, that there was a perforation in a retinal detachment case.
Yeah, Abhishek, just one point I'll add. At the end, you went again with the flute, with the soft tip to the hole. What nowadays I have started doing is at the end again, because after 2-3 minutes, by the time you have done laser, some fluid has already accumulated there. So even if you would have again gone to the disc, the flap will come. You need not actually go near the Because nowadays, one thing which I do is after your FG, I wait for 2-3 minutes, even in an uneventful hole, let all the fluid accumulate back again, and then go and remove from the disc. And that definitely makes my hole closure on day one. That's something which I have, because once you do a FG, after 1 or 2 minutes, all that peripheral vitreous, it's like pressing it and all water drains to the posterior pole. And that will keep the hole open. So once you have completed all the steps, you can just wait for 2 more minutes. Again, go with a flute and remove that from the disc.
Yeah, so that was done in this particular.
In this you have
case.
done.
So,
But I was only wondering, you
Yeah.
went to the hole, you could have even gone to the disc and did that. That would have again become.
Yeah. I want to give one message, Rajiv and Abhishek and other people here. Because as a cataract surgeon, no, I would strongly recommend and advocate what Manavi told. Don't put a needle. Don't put a needle and give a peribulbar anesthesia. Many of the cases, you can do topical anesthesia without any problem at all. Or if at all you want to, if the patient wants a little more comfort, you want a little more comfort, just open up the lower nasal conjunctiva, blunt cannula, give a subtenons. That can work even for a vitrectomy surgery. And high myopes in vitrectomy, Manoj knows about it, what we are doing in setup. Our anesthetist who gives, he is a very senior person, very experienced. But still we have had in normal axial lengths also, like what Abhishek is thinking in vitrectomy. Vitrectomy, we use a smaller gauge needle. For example, 26 gauge shorter needle we give so that we don't go too much posteriorly while giving the peribulbar block. And if at all, we augment that with the subtenons if necessary. So because in high myopia, RD, vitrectomies, most of the patients are high myopia. So we do not know how much of axial length and peribulbar will be safer. I think we are, I have to go to the next one. I think we've got a very clear message in this. Abhishek, wonderful video, really fantastic video it is.
In the interest of time, we'll move on to Dr. Manvi Sindal's presentation. Manvi, again, requires no introduction. She is a dear friend from Pondicherry. And we also welcome Dr. Chetan Rao here with us, senior consultant from Shankar Nethralaya, Chennai. He has joined us. Over to you, Manvi.
Yeah.
Thank you, Manoj, and thank you, Dr. Mohan Rajan and SN Alumni for having this wonderful webinar and for inviting me to be a part of it. And since my video has voiceover, this is time for me to relax for 5 minutes while you all enjoy the video.
Very nice. You share the screen. Sound is not coming.
Sound is not coming.
Manvi, you cannot relax. You have to
Manvi,
speak.
sound, please.
You talk, no?
Restart your video also.
You can restart, and when sharing, you can optimize to the sound. It shows two things, video and that. You can just click that.
Okay, I'll try that because the voiceover is there and I can hear it. Yeah, optimize video clear and share sound. Okay.
Yeah, now
Yeah,
it will
yeah,
come.
Yes. Thank you for the tip.
That's what we are inviting you for webinar. You need a lot of tips.
Okay, I hope it will be audible now.
Mastering PVD induction in challenging retinal surgery, tips and techniques. In the world of vitreoretinal surgery, inducing a posterior vitreous detachment or PVD is nothing short of an art. Let's take a closer look at the meticulous process of inducing a PVD. After creating 3 pars planar ports, we start with a minimal anterior vitrectomy. The cutter is guided carefully towards the optic disc with suction as our primary tool. We embark on a controlled separation of the vitreous gel from the retina. As we approach the optic nerve head, we grasp the vitreous attachment with suction. PVD is induced by gently tugging on this attachment by a sweeping circumferential movement moving towards mid-vitreous cavity. Once the posterior hyaloid starts separating, the PVD is extended in all 4 quadrants. Our goal is to gently separate the vitreous from the retina and advance anteriorly as we move towards the periphery. Once the posterior hyaloid is separated and the V's ring is visualized, we switch the cutter back on to clear away the vitreous. The induction of PVD encompasses various approaches tailored to each unique pathology. High magnification aided by the wide-angle visualization system's macular lens enhances visibility, simplifying the PVD induction process. Intravitreal triamcinolone acetonide can be a valuable adjuvant. Its crystals adhere to the vitreous, making it visible and easier to engage in the cutter, facilitating precise PVD induction. Alternatively, brilliant blue G can be used to stain the vitreous blue, differentiating it from the retina, a valuable aid for precise PVD induction. In challenging cases with dislocated crystalline lenses or dropped nuclei, inducing PVD is crucial. The weight of the lens pushes the hyaloid downwards, but we have a trick up our sleeve. We initiate PVD induction in the infranasal quadrant, avoiding the posterior pole where the lens lies. Once PVD is achieved here, we can easily extend it to other areas, lifting the hyaloid and overlying lens with suction. For retinal detachments caused by a horseshoe tear, pre-existing PVD may not extend beyond the break. In such cases, meticulous PVD induction is essential, even if it's challenging in areas anterior to the break. The vitreous must be shaped with precision. In pediatric eyes with retinal detachment, the lack of pre-existing PVD poses a challenge. The mobility of the retina can be tricky. After inducing PVD over the posterior pole and trimming the vitreous, we stabilize the posterior retina with perfluorocarbon liquid. Performing fluid-fluid exchange can help flatten the bullous detached retina in periphery, further aiding induction of PVD. Then we can induce anterior PVD. In diabetic vitrectomy, where the posterior hyaloid is adherent with fibrovascular proliferations, we avoid using suction to induce PVD. Instead, we meticulously separate the hyaloid in a systematic manner. After making an opening in the posterior hyaloid, the edge is engaged in the cutter and hyaloid is separated gently in a clock arc by clock arc fashion, avoiding any traction on the FVPs. The separated hyaloid is then truncated before moving to the next section. Once all points of attachment have been separated, the peripheral hyaloid can then be lifted with suction. In complex cases with combined tractional rhegmatogenous retinal detachments, truncation of the cone, we segment and delaminate the posterior fibrovascular proliferations, causing traction, ensuring the removal of the posterior hyaloid with all membranes. Finding the correct surgical plane of dissection between the true posterior hyaloid and retina is paramount for a clean surgery. In summary, inducing a PVD is a fundamental aspect of vitreoretinal surgery. Its impact on the procedural ease and patient outcomes. For us, it represents the essence of surgical precision and our commitment to optimal patient care and visual health. Thank you.
Wonderful. Fantastic.
Thank you
Brilliant, Mavi.
for those
Lovely.
some tips on PVD induction.
Yeah, I think Dr. Chetan Rao is here. Can we have some pointers from him?
Welcome, Chetan.
Yeah, sir.
Yes,
I
sir.
think Madhvi has covered everything. There's nothing to cover.
Okay. Aravind,
Yeah.
sir.
It can be very
No,
difficult.
great video.
I'll tell you where some cases it's really difficult, especially if you have a very large glaucomatic cup. It's almost impossible to pull the vitreous out from the cup edge. You somehow you don't get any counter traction from the vitreous. There's just a single sheet. That's when you have to use forceps and try to peel at the edge. It's a little difficult because sometimes you can end up harming the leftover, whatever nerve fiber layer is there. But then that's the only way you can actually peel it off. And once you get a little edge, and then you can start using maybe a soft tip cannula and just rub along the surface of the thing and just create that the space, because the infusion is anyway high. So it somehow dissects through the plane once you just get a plane at the edge of the disc. But I found it most difficult in very large cups, glaucomatic cups, trying to induce a PVD. It's almost very, very difficult to remove the hyaloid at the edges of the disc. But yeah, you need forceps, and with the help of soft tip cannula, you can use it. Yeah. That's one problem that I've faced.
Yeah, what Chetan said is correct. Sometimes you may need to use a forceps. The other thing is a very high myope. Sometimes it's high myope that your cutter doesn't reach the disc at all. These cases, like you did for your nucleus, sometimes you can start from the mid periphery, and because the cutter is not going to the disc at all, start that, and then gradually once you get the plane, then that gets separated. That's again one way of dealing. Many of diabetics are problem because there is vitreoskisis. And these cases, definitely the second membrane looking for it is very, very important. That's how you get a good plane for dissection. Anything, Mahesh, you want to add?
Yeah, two situations is high myope. We think that there may be PVD, but there will be a
Correct.
cortical layer which will reproliferate and cause. That's why even in some myopes, inferior RD, we prefer buccal rather than.
Correct.
So the second situation is breakthrough vitreous hemorrhage. Sometimes the breakthrough vitreous hemorrhage in AMD or PCV, that altered blood gets very sticky to the retina. And if you try to peel it in whatever method, it's very difficult to get a cleavage. All of you might have faced. That is one thing. Once you are in the plane, it is easy. Then you can pull, and but sometimes it's very difficult to get that. That is one difficult situation that we find. Excellent presentation. Good teaching video.
Manavi, any suggestions or tips for pediatric vitrectomies, PVD?
Yeah, in pediatric vitrectomies, again, PVD induction can be extremely difficult, and the posterior cortical hyaloid can sometimes, despite the best of the efforts, get left behind. Here again, like what Dr. CR sir was saying just now, using a forceps, staining with the IVTA, using forceps to get the first bit, and then after probably you have a small PVD on the posterior area, using PFCL to stabilize the posterior retina, and then extending it to the periphery can help.
Abhishek, you wanted to add something, Abhishek?
Yes, so sometimes where it's really difficult, and there is just a thin vitreous sheet and you just cannot find the PVD separation at the disc. You can always also try doing it from the edge of the break. Let's suppose you have a mid-peripheral break. There are instances where I have done that, where I was finding it extremely difficult and it was so adherent that it was not coming off from the disc. I started the other way around, because there is a break at the edge of the at the retinal break. There is a break in the vitreous, so there is a potential gap there from where you can start peeling and create a cleavage, and then go to the disc, and then go around and clear off. Lift it off the rest of the retina.
Correct.
Very nice video, Manavi. Superb. Learned a lot. Manoj?
Yes, sir. Any comments from anyone else? Any further comments?
We go on to the next presenter. No problem.
Okay. Kumar, are you ready? Yes.
Who's ready? Next.
Dr. Nandi? Krishnendu Nandi?
Krishnendu, I can't see him. That's what I'm asking. Kumar, are you ready? Then you can go.
Yes. I can start. Just a minute.
Saurav Kumar, you can start.
Are my slides visible? Are my slides visible now?
Yeah, slides are visible.
Yeah. Good evening, everybody, and thank you, SN Alumni Association, for giving me this opportunity. So mine is a different topic, actually. It's not a surgical video. So I will be talking about imaging Henle fibers layer. So let us begin with a couple of scenarios. This is a patient, right eye of a patient of optic disc edema, and he has a radiating hard exudates in the macular star formation. This is very typical of optic nerve head pathologies, and it's not seen usually in diabetic retinopathy or other RBOs. So this macular star is because the hard exudates are located in the Henle fibers layer. Similarly, this is a OCT line scan for patient with acute macular neuroretinopathy, where we have hyperreflectivity of OPL and ONL and disruption of ellipsoid zone. So again, in this case, we have got something to do with the Henle fiber layer, which we'll see again later. And this is a simple case of central serous retinopathy. However, apart from the subretinal fluid and serous PD, there is something else in the inner retinal layers, which is not normal, which doesn't look normal because I've marked with the yellow arrow that area is appearing as hyperreflective. This hyperreflectivity again has something to do with the Henle fibers layer. So where exactly is the Henle fiber layer? We do not see anything in a normal OCT scan of a patient. So this is a custom high resolution Heidelberg spectralis OCT scan, line scan, which clearly shows Henle fiber layer as a separate zone in the hyporeflective outer nuclear layer. It is present on the inner side of the outer nuclear layer towards the vitreous side. But this is a custom OCT machine scan, and it is not available in usual clinical practice. So let us go further. So what exactly is Henle fiber layer? Henle fiber layer is unmyelinated photoreceptor axons and outer molar cell processes. These two areas form the Henle fiber layer. And pardon me for giving a histological picture here, but just for the sake of explaining, the orange color here shows the molar cells, yellow and pink are the rod and cones. So this slanting thing is the area where is located. So, but it is very difficult to visualize because it is quite homogeneous and it is quite isoreflective to outer nuclear layer. So it is very difficult to see it. But this is a OCT line scan of a myopic eye. Here, the Henle fiber layer has become easily visible because it is hyper-reflective and seen only on the one side. So we should not make a mistake of thinking that it is a thickened outer plexiform layer. It is not the thickened outer plexiform layer, but simply the HFL has become visible. So when does the HFL becomes visible? It can become visible physiologically, or it can also become visible in certain pathological case scenarios, like when there is an ischemic injury to this area in a case of deep retinal ischemia. So coming to the physiological scenario when the Henle fiber layer become visible, which is called directional reflectivity or directional OCT. So what is the meaning of the directional reflectivity? It means that any layer of the retina is visualized best when the laser light falls as much perpendicular to it as possible. If the light is perpendicular, then the reflectivity will be maximum. So this is a image of a pupil and the laser light entry point of OCT laser light entry points. So directional OCT is not a new OCT or something, it's just a new term, and it can be obtained on any OCT machine. What we have to do is just shift the laser entry point, just take an off-axis image of the off-axis OCT scan. And in fact, it is inadvertently obtained in many scenarios when the operator is not centrally aligning the OCT machine centrally, then it is off-axis and we can see the directional property of OCT and we can visualize the HFL. So like these three images, the top image shows here that the entry point of the laser light of OCT is central, so there is nothing in the outer nuclear layer, we cannot see anything. But when the entry point of the laser light of OCT has been shifted temporally, then we can see that on the opposite side, because the light is falling perpendicular on the opposite side, nasal HFL is visualized, marked by the yellow arrow. Similarly, when the laser light entry of OCT machine is shifted nasally, then temporal Henle fiber layer becomes visible. It exactly happens in the opposite direction. So what is the implication? Implication of this thing is that we can erroneously assume that there is a thickening of OPL or even narrowing of outer nuclear layer, because if we do not consider that it might be because of directional property of the OCT. So this was about the directional part. So what are the scenarios when pathological scenarios when the Henle fiber layer become visible? So we should consider that in any case of deep retinal ischemia, we may be dealing with the hyperreflectivity of Henle fiber layer and not with the hyperreflectivity of outer nuclear layer or OPL. Like this is a case of acute macular neuroretinopathy. So the area of interest has been marked here. We can see that there is hyperreflectivity of outer nuclear layer and hyperreflectivity of outer plexiform layer as well. And also we have disruption of ellipsoid zone. So this is the area, and we can see that this is a classical picture of what we consider as acute macular neuroretinopathy. But excuse me, this what we are seeing here is just hyperreflectivity of OPL and Henle fiber layer and optic outer nuclear layer and disruption of ellipsoid zone and interdigitation zone. So this OCT picture is called ASHH, or hyperreflectivity of Henle fiber layer. And this is just an OCT picture, and it is not what I mean to say. If we get this OCT picture in any patient, we are not going to label it as acute macular neuroretinopathy, because acute macular neuroretinopathy is a disease entity which is seen in young adults and where with a history of vasoactive substances and all. But that's a separate disease entity. But this OCT picture per se doesn't make it a diagnosis of acute macular neuropathy. This OCT simply means we are having a hyperreflectivity of the Henle fiber layer, and this OCT picture can be seen in many other scenarios like trauma or any branch retinal artery occlusions also, and then we do not call it as acute macular neuroretinopathy. What is the clinical implication of all this reflectivity of the Henle fiber layer? That it has been seen that pathological hyperreflectivity of Henle fiber layer denotes an acute damage to the HFL, and acute damage to HFL also leads to widespread degeneration of photoreceptors. So it's a worse prognostic marker for any retinal disease, any retinal condition if we have HFL hyperreflectivity. And in cases of PAM and AMN, when we are dealing with deep retinal ischemic diseases, we should take into account that whether we are visualizing HFL or it is just hyperreflectivity of OPL or ONL. So this is all about the initial interpretation of HFL, and the science is still evolving. Thank you very much.
Excellent presentation, Kumar.
Yeah. Have you published this?
Yes.
Sir,
Yes, sir.
have you published this?
So yes, sir. The couple of images here have been published. Yes,
Published.
sir. Yes.
RRN sir, your comments?
Yeah, great. Do you feel that near infrared reflectance or any other multimodal imaging also can pick up the Henle fiber layer in a better manner? Or any other way? One is you showed OCT, but do you feel any other multimodal imaging can pick it also? So you can also pick that up?
So it has not been studied yet, sir. But sometimes in multicolor imaging, the reflectivity changes, the contour of the color changes, and we can say that it is either RP, either superficial or deep or intermediate. So it is slightly less red than the atrophy of the RP, but still it's one or two cases, single case, anecdotal cases.
And one thing, what you showed, that layer, the one hyperreflectivity, we used to see more when we used to do a EDI.
Yes, sir.
Extended depth, definitely we used to see, and probably with EDI also you can make out Henle fiber little more better, because again it is a deep imaging, and maybe because of directional what you said, but one of the observation when we used to do EDI a lot, that time this layer always used to be confusing, that what is happening. Chetan, any thoughts?
Yeah, so one important clue to actually the Henle fiber being pathological or not is that if it becomes hyperreflective truly because of like ischemic injury or inflammation, is if you see the lower layers will be attenuated. In the directional OCT, if you see, the lower layers are absolutely the same reflectivity as the surrounding areas. There won't be any change in the reflective. So to true pathology, if it is there in the Henle fiber, you will see the underlying layers, that is the ellipsoid zone, they'll be attenuated because of the overlying disease. And most of the OCTs are in the infrared range. And infrared actually has when there is tissue fluid in the media, it has a lot of, it's got a very high absorption coefficient. So infrared cannot pass through fluid media very easily. It gets absorbed. So if you see, because most of the OCTs that you have nowadays is 810 nanometer or 1050 swept source, all of them are infrared range. So infrared gets absorbed. So it's got infrared has got a very high absorption coefficient in liquid media. So whatever, if there is media, liquid, whatever, edema in the tissues, it's not going to pass down. So there is going to be attenuation of the lower layers. So that is the very, what is shown in myopia. If you have a picture, do not take always the horizontal. Also look at the vertical scan. Then you can clearly show that that is not a pathology, because one of the two scans will always show that directional OCT, either the vertical or the horizontal. That's all.
Excellent input, sir.
No, I just want to
Sir,
know from Saurabh, Manoj, does this Henley's fiber can be accentuated with all the OCTs, or you need only spectralis for that?
No, sir, it can be seen on any OCT machine.
Any OCT machine.
All the
Any
OCT.
OCT machine. Yes, sir. Yeah. These images are from Zeiss, actually. Couple of
Zeiss.
images were from Zeiss. Yeah.
Thank you. Very nice.
Thank you, sir.
thank you, yes, as always, for great presentation from your end. And in the interest of time, let's go to the next presentation by Dr. Krishnendu Nandi, a dear friend from Calcutta. K9, are you ready, please?
Yeah, and thanks for giving me the opportunity to present, and thanks to my sincere thanks to my seniors, my teachers and friends. So I'm going to share my screen. I'll be presenting a video. Is there audio? Is the audio is their audio is there in the video?
You play it.
Play it. Start the video. Please start the video.
It is already there. Started, sir.
No, it is not. We are not seeing it.
Okay.
You can
Then,
share the screen and that time do that optimize for video.
Yeah.
You again reshare.
Then
No,
I'll
close the
stop,
thing.
yeah.
Stop sharing.
Yeah.
When you are resharing, you can optimize to video. There is one box. You can just put that.
Optimize to the video. Yeah, it is there.
It's not playing.
I think you play the video first.
Yeah.
No. See, you need to open that video and keep, and then share, and then click.
I have done that. And let me
Open that video. First, you open the video and keep it there on the desktop. Then, have you opened the video, Krishnendu?
Yeah, I have opened it.
Then you share now.
And share the screen.
And share the screen now, and then click on that. Manoj will go on to the next speaker. Then
Yes,
come
sir.
back to him.
1 second. He has come, I think. Open the video, K9.
It is open. Is it visible to you?
No, it's not.
The
Not
folder
visible.
is visible. so you
I'll
can
give you
play
another
with it.
another
It's
option.
not shared. That's a problem.
No, I'll give
I-
another option. You can, by the time I think Harshit can present, but what you
Yeah.
do, you open a new PowerPoint and insert that video in that, and
In
then
the
share
PowerPoint.
the PowerPoint. That you
Okay,
can do by the
better,
time
yeah.
Harshit
okay.
can
I'll do
present
that.
it.
I'll do
Put
that.
it in the
I'll do
PowerPoint.
Okay, I'll do that.
So that it'll be easier for you to share the PowerPoint.
Tandav or Harshit, any one of you are ready? Tandav or Harshit? Harshit, are you ready?
I'm
Harshit.
ready. I'm ready. I could do it.
Okay, fine.
Okay, go ahead. Tandav, go ahead.
Are my slides visible?
Yeah, visible. Just make it full screen.
Yes, yes, yes. Right? Fine.
Fine.
Yes,
Okay.
perfect.
So I just have an interesting case, or at least a case scenario, which I encountered. So this was a 60-year-old lady who presented to us with reduced vision in the left eye. She already was injected with about 8 injections of brolucizumab.
Can you be a little louder,
And
Tandav?
she was already given. Am I audible?
It's better now.
Yeah. So she had already been given 8 injections of brolucizumab, and she had come just for a second opinion. She always wanted to go back to her primary doctor for the repeat injection if needed, but she was just wanted to know whether the treatment being given was correct or not. And she also had a systemic history of G6PD deficiency. So on examination, she was having PCI. She was pseudophakic in both the eyes with the best corrected visuality 6/6 in the right eye and 3/60 and 24 in the left eye. The right eye was essentially normal. Going on to the left eye fundus picture, as you can see, there is a subretinal scar. And on OCT, you can see a loss of foveal contour, intraretinal fluid collection, a little bit of bacillary layer detachment, and subretinal scarring. This is just another image which shows the exact same thing. So now coming on to the management, it is obvious that the patient had some active CNVM and needed some form of an anti-VEGF injection. But which one was the question? Because I was really not sure. I really had no idea what G6PD deficiency is, because it was something I read in MBBS and I had absolutely no clue what it was at this point in time. And I was really not sure whether injections are safe in such patients. So just to speak a little bit of G6PD deficiency, it is a genetic disease which affects red blood corpuscles and results in premature hemolysis, which causes anemia, jaundice, shortness of breath, tachycardia, and fatigue. Now, these episodes of RBC hemolysis are triggered by bacterial infection, viral infection, eating fava beans, or inhaling pollens of power plants. Interestingly, it also can be induced by a lot of drugs, and that is where my worry was all about, such as anti-malaria drugs like chloroquine or primaquine, antibiotics, sulfa drugs or quinolones, analgesics like aspirin, ibuprofen, naproxen, a host of other drugs also. Now, my clinical dilemma was anti-VEGF drugs, are they safe in G6PD deficiency? And I just had no clue how to go about it, because the patient was sitting in front of me and I had to get a ready-made answer. So what I did was I just asked Meta AI this question: are anti-VEGF drugs safe in G6PD deficiency? And uh, a little bit of artificial intelligence and how it helps in our medical field. It helps in analyzing the data which is available, helps in assisting in form of diagnosis, provides treatment recommendations, helps in predictive modeling, and also there is something called as clinical decision support system, where it helps us in making clinical decisions based on the current level of evidence that is present. So in my case, when I pose this question, which anti-VEGF agent is safe in patients with G6PD deficiency? So it analyzed all the available data, unlike Google, which gives you various sources and you have to look up at each of these sources. Here, it analyzed all the data which is available, and it neatly divided the entire answer into two specific answers. That is, drugs which have no specific warning, such as aflibercept, faricimab, and bevacizumab, and the other group where manufacturer recommends specific caution, that is ranibizumab or brolucizumab. Now, looking at this particular answer, it looks very simple, that we have to go with the drugs on the left side, that is aflibercept, faricimab, or bevacizumab. But that is what I had conveyed to the patient. But when I looked at it in further detail, what it is saying is that these particular drugs do not have any specific warnings. It is not saying that they are safe. And on the other hand, the other drugs where it says the manufacturer recommends specific caution, uh, while it says caution, it is still up to us to decide whether in that particular patient these the limitation of artificial intelligence and the principle of GIGO, that is garbage in and garbage out. That is, whatever results are given to you is based on the data quality and the bias that we feed it. And the results that come to us without any human empathy or understanding and without any understanding of the context. Moreover, there are also regulatory and liability concerns. For example, I checked whether there are any regulatory uh, rules with regards to artificial intelligence, and the only answer that I got is the government is this process of formulating, but as of now, there is nothing like regulations. To sum up the entire thing, I came up with this post today by Elon Musk, whose company is also developing an artificial intelligence platform called as Grok. And what he said was, you submit whatever scans you have, and our Grok will analyze, and it will give you, though it is in an early stage, it gives you very good results, and it is going to become even better in the future. To which an Indian doctor said, I tried what you have said, but it missed a lot of findings, and it missed ECG for an ICD tube. So the doctors at this point in time are not in any particular danger. Without any human element, artificial intelligence isn't going to help. So therefore, for a safe and effective artificial intelligence driven medical decision making, we always have to have a human oversight and review, a rigorous testing and validation process, continuous monitoring and updating, transparency and explainability of the research, and integration with human clinical expertise. Thank you.
Good presentation, Tandav.
Very good. I didn't know that
Thank you, sir.
G6PD can have this problem.
No, great presentation, but I think what you gave the last message is correct. Don't rely on chat GPTs and other AI system. But I would say your again garbage in, garbage out is important. I'll just go a different way that if suppose I have to search this, rather than putting that which of the anti-VEGF is safe, first thing is I'll try to revise which are the drugs which cause in G6PD the hemolytic crisis. That would be my first question. And second question would be what causes it? Why these drugs cause? And once you know that it is the oxidative damage and it is the direct RBC toxicity, I am safe because I am dealing with a blood-retinal barrier. I don't feel that any of these drugs will actually pass through. And you can then, if you want to really get a good answer, you can again write that there is a blood-retinal barrier. Do these drugs really cross and cause the G6PD thing? So you can play around. Sometimes it gives good answers, but yes, the question you have asked is most important. That becomes an important thing.
Mohan,
Yes. Yeah.
no. I say G6PD is very common in Parsis, and that's why from 88, when I went from Madras to Bombay, I had to do every patient at G6PD because we don't know who's positive. So we have a lot of physicians who are dealing with the Parsi physicians. So I refer them and take their clearance. So instead of doing those days, we didn't have Google or anything. So we had Parsi physicians who can certify that, okay, you can take up this patient with the G6PD and avoid the list of drugs. And anti-VEGF, I don't think I have any problem in G6PD. It was a mind opener to me because I am not doing G6PD. Probably, I don't know. I'm treating a Parsi patient with aflibercept, and probably I have not done the G6PD. He was treated earlier in Greece, and now he is being treated by me. So anyhow, I think he doesn't have a problem of G6PD. But anyhow, good to know, because when I was doing most of the patients with general anesthesia in 88, G6PD was important because otherwise it can have problem with the anesthetic drugs also.
Is there
Very good
any
presentation.
article which says G6PD deficiency case, after anti-VEGF there was a problem? Is there any case report available?
I don't think so.
No, sir.
At least
No, sir.
No.
I don't think
Okay.
so, but
I think
because
These are based on the literature which is provided by the company.
Company. Okay. Okay.
Yes.
Anyway, good
I think
argument.
I think so. As Rajiv said, there's a blood retina barrier. So I think whatever intravitreal condition injection given that to in the dose, G6PD patient will not have problem. This is my thinking. I don't have any academic, what do you call,
So,
publications
I
on
want to
that.
add to what
Yeah, please,
I want to
Chetan.
add to what Rajesh said, that this is another what do you call learning from AI, is that something called prompt engineering. So
How
Yeah.
good
so
is
the
your
prompts that
prompt?
you give,
Yeah.
the prompts
So
that you give
I did that
to an AI.
exercise now, what I told exactly, and it started telling the GPT-4o. It gave me three things. It said that all these are the drugs which are there. Then I asked about blood retinal barrier. So it said, yes, it is important, but there are two things which are very crucial: the lipophilicity of the drug and the
Yeah.
molecular size and the active transport mechanisms. So if these are involved, then they can cause to some extent, and they've also divided it into what can be the potential triggers of hemolysis. So that's what I'm telling, that if you put a proper prompt, you can get a very good answer.
So
In
like
fact,
Rajiv, I think, and Rajiv and we have done a study together for the
Yes.
ChatGPT question. So the
Correct.
question
Correct.
is that you have to really frame the question in such a way that it's actually you are predicting the answer. So you know that this could be the answer. So let me ask the right question.
Yeah, you have to put a
So
human intelligence and put the question, you will get some
yeah, so
answers.
I want to get this answer. So let me put the question in this way. It's like, let me rephrase, like the lawyers tell in the court.
Yeah.
Let
Yeah.
us rephrase the question. I mean, to
HI
get a
over
different
AI.
answer.
It's HI
So
over
Mahesh
AI.
know that. Yeah, it's always HI over AI.
Now, I was just asking the panelists, they were showing that Pegenex, because of Pegenex, the deeper penetration is possibility of crossing the blood retinal barrier when compared to the other anti-VEGFs.
No, I don't think so. But in G6PD, one of them, which I was aware, like we know that there is hemolysis, there is also more thrombosis. G6PD is one of the risk factor for even RVOs. So definitely, no, brolucizumab would not be one of my first agent to use in this, because that increases thrombosis, chance of occlusions, occlusive vasculitis. Probably that would be a bit worry.
Good. It's an eye-opener for all of us. Yeah.
Yes, sir. Dr. Krishnendu, are you ready, please? Krishnendu?
I'm ready. I'm just restarting the thing again.
Yeah, just go
Yeah.
to screen share.
Yeah, I'm sharing. And I'm inserted in the PPT mode. So I'm opening in a PPT. So is my
now it's
PPT
better.
visible?
Coming up, yes.
It is there.
No, it's coming up.
It
The
is
video
there.
No,
Is my
it's not open. You open it and then share.
I have opened it.
Okay.
Is there any connection problem?
No, there is no connection.
Doctor, I realize that the Zoom version you're using is outdated, doctor, because we see a gray screen. So
Yeah.
that is the reason you see that version. The Zoom version has to be updated.
Update my
Is
Zoom
there any
version.
way of doing it, Sai?
Doctor, now, I mean, probably what I can do is, if any other speaker is going to take over this talk, I can ask Dr. Krishnendu to share the data to me and I can run it on his behalf.
Okay, fine.
Be better. You
Yes.
mail it to him.
By the time we will move to Harshit, I think.
Yes.
Harshit, are you ready?
Yes, sir. Can you see my screen?
Yes, it's visible and audible. Go ahead. Full screen, please.
Yes, sir. So thank you, Manoj, sir, for this invitation. Clearly, I'm the junior most here, so I cannot clearly teach anybody, but I have an experience to share. So that's the reason my title actually is not a statement, rather a question. So, at the end of the presentation, I'd like the seniors and my mentors to tell me as to was it actually a daring challenge or just plain lucky or rather unlucky. So the case starts with this. This happened last year. This was a 60-year-old male who came with complaints of nasal field loss in the right eye for about 2 days. He had a history of cataract surgery in the same eye 4 years ago in the US, and he had also a tear which was repaired by retinal laser 3 years ago. So this was the presentation. He came to me. So apologies for this initial few videos because I didn't have the optos at the beginning, but the patient presented with a best corrected visual acuity of 6 parts in that eye, and the anterior segment was good. There was pseudophakia, the IOL was in the bag. This is a schematic presentation here. So basically it was a giant retinal tear from about 7:30 to 11 o'clock hours. And you can see that there was a mobile rolled edges along with subretinal fluid, which was about 1 to 2 disc diameters posterior to the posterior flap, but the macula remained on. So obviously the next step in the thought process was, we go ahead with vitrectomy, but, we were discussing with the patient and, we did something which was probably not indicated even in textbooks so far. So we did pneumatic retinopexy because that was coming up, and I discussed with the patient. Obviously all the consent was taken and we ensured that the patient knew and patient did understand the implications of the same. And to even begin with, I told him that there's only about 20% chance and we may just, have to convert to vitrectomy. So we went ahead, did a 0.7 cc of SF6 and tap of 0.3 with the head down position, lateral and left lateral position. So, and from day 2 onwards, the retina began settling superiorly. We started adding laser.
I have to transfer because it's a large video. Probably 500.
No, switch off the audio. Don't do.
Where you have shared? Where you have shared?
Manoj,
Krishnendu, can you mute? Krishnendu, can you mute yourself, please? Krishnendu?
Yeah. Sorry.
So no problem, sir. So the retina began settling superiorly, and the inferior retina was still detached from about 7:30 to 9 o'clock hours. So we decided to add a second bubble, about 0.6 SF6 and a tap of 0.3, and complete the continue the left lateral position. And day 7, I was able to take help of Dr. Vatsal Parikh, who's a senior SN alumni. He's halfway across town for me, and it was a task for the convince the patient to get this because I don't have the optos imaging, and I took sir's help throughout the journey going ahead. So you can see that the laser marks was start of different types were there because of the different days of laser and the 2 gas bubbles, and the retina was attached here. You can see at the end there was this giant retinal tear. Subsequently, we were following the patient up with this ultraviolet field imaging. There was hazy vision, but it was getting better from the initial days. We were able to see the scarring laser marks, but the problem was the inferior retina. The ultraviolet field was still, we were having a challenge because the technician probably wasn't able to do it well. And because of the hazy view, even I was not able to see the fundus pretty well. Subsequently, here you can see that there's an entire tear. Finally, we can at least observe the tear. And here, these are the laser marks that are scarred. I was still not sure of the inferior retina. I was having this doubt that it was in my mind if it's still off. I took help of sir once again, and here this is where the ultraviolet field swept source OCT helped us, probably get to the picture. So here you can see that the retina, we are doing the scan here, and so the retina was lifted here. There was probably, it was loculated, but it was still something. So you can see there is the retina and there is the SRF here. So it was probably loculated inferiorly, but it was still giving me some goosebumps as to if I've, I've gotten away with it. I just added a little bit of laser, hoping things work out. The patient came to me like 2 weeks later on day 40, complaining of temporal field loss. So again, apologies for this. The patient was seen by me, so it was just on the smartphone fundus. Again, the patient had nasal RD from 12 to 4 o'clock and an HST at 1 o'clock. So clearly at this time, the patient, even I was 100% sure I'm going to go ahead with vitrectomy. But the patient himself was like, can we try another bubble? So again, I repeated the PNR. We gave it 0.6 SF6 and a 0.2 tap. The POD one, we started laser. The nasal half was lasered. And fortunately, by day 70, the patient was symptomatically as before. He had a good BCVA, the retina was attached, and the laser scars were seen, but there were no new lesions. In this duration, the patient went to the US again, and I thought that, we did try to get back to him, but clearly so I felt, the mind lands up thinking negative. I was thinking that maybe he's got a detachment again and he's gone to another doctor and I've lost the patient. So, that paranoia kind of creeped in. But lo and behold, the patient came in just a month ago, actually. I could see that the right eye, so I sent on that day itself, I sent the patient to sir. Vatsal sir, you can see the right eye was still holding up, but he came with a diminution of vision in the left eye, about 25 days duration with a subtotal macula of maculogenous retinal detachment with a counting finger vision. Now, at this point in time, we were kind of sure, and we could see that there were 2 horseshoe tears that I could see. At this point in time, I was kind of sure that, I want to go ahead with the vitrectomy, but probably the patient had a good result in the pneumatic retinopexy. And, he convinced me rather than me convincing him that why don't we just give a tire to the bubble. So again, we went ahead with the pneumatic retinopexy, but 0.7 SF6, head down positioning and the left lateral positioning for about a few days. Subsequently, we did, start the laser for the patient. But as you can see, on the few days, the macula remained flat, but there was SRF inferior. Now, I wanted to observe. I was calling the patient, regularly. So on the subsequent day, I could see that the SRF had increased. And at that point in time, I discussed with the patient. As you can see, the SRF was approaching the fovea, and we did the laser to the actual nasal HSCs which were there. The retina, the macula was still partly attached. I discussed it, should we go ahead with vitrectomy? We went ahead and did a pneumatic retinopexy yet again. Again, it's anybody's guess if it was a right or wrong decision, but this is what we went ahead with. Again, you can see this was the presentation in the morning, and we went ahead with 0.6 SF6. And in the evening, I saw the patient, and to my dreaded, worry, the patient had 3 or 4 bubbles of subretinal gas. Now it was about 7:38 in the at night. I clearly couldn't do much. So what I did is try to indent, scleral indent, and ensure that I could get off a few bubbles. And I'd spoken to Dr. Rajiv Muni, who clearly does a lot of pneumatic retinopexy, and also Dr. Vatsal Parikh. And we were hoping that, if I can get a couple of bubbles off. I was able to only get a couple of these small bubbles off. I sent the patient next day to Sir, and clearly you can see here that there was, a gas in the vitreous cavity, but here there was this gas which went subretinal, and we were not able to remove it. So obviously the next option was to go ahead with a vitrectomy. For some odd reason, we were not able to do so. So we followed up the patient, closely. We were able to see that the macula remained attached throughout. The inferior retina, whatever we could see, was relatively attached. Here you can see that the patient went to Sir again. The temporal retina remained attached, but there was this, and the gas bubble did get absorbed, and the macula was still flat. But we did ultrasound to ensure that and we got to know that there is an inferior RD. At this time, we did not want to be brave or take any drastic steps. We went ahead. I was not in town. Fortunately, Vatsal sir came to my rescue again. We did a vitrectomy 2 days later with a counting finger vision. The patient had the macula and the retina was attached with buccal, of course. And this was the last follow-up just a few weeks ago. And the patient has again gone to the US. You can see that the right eye, the retina, and the left eye with the oil meniscus that we can see here, the retina remains attached. And the patient had a BCVA of counting finger 3 meters in the left eye. So the key differences that I would just highlight that in the second eye, I think my indirect ophthalmoscopy was probably not the best, because there was a break that I clearly missed that was probably at around 4 o'clock position in the left eye. And that was probably what was, the biggest reason for its failure. And in this visit, the patient was slightly more lackadaisical. He did not do the positioning as I had asked him to do. Every visit, he would just be like, no, sir, I've not done any positioning. And the other learning would be that I could have probably been more meticulous in trying to coalesce the SF6 bubble intraoperatively by trying to tap. Again, there is a query about doing this procedure intraoperatively or not. But these are a few things that I know that I could have done better. And this is how I tackled this case. So I'd be happy to learn from my seniors if they would do anything differently. Thank you so much.
Excellent presentation,
Incredible. Harshit. Fantastic.
Hats off to your perseverance also.
Yeah.
Dr. Araran sir, your thoughts?
Yeah, I think definitely will not be managing like this. See, Harshit, I'll tell you, if you follow, you do this multiple gas injections, I'm sure you'll develop hypertension. Because every patient following for 1 year and having that sleepless night that there are still the retina is detached, you're not seeing. I think the select cases where pneumatic retinopexy definitely plays a role are there. But these type of case, you already experienced a HST developing in the other quadrant. You can have a large tear. We have seen large tear going till the disc, becoming inoperable RDs. No, he was lucky that so many times you have injected, nothing happened. But no, I agree. Patient was not willing. Many things are there.
What I would want to say is I did not. So I forgot to mention that one line. It is not something that it's not a giveaway. I mean, the point is that this is not an ideal case, and I do not want to give that message that you should be trying this.
This should not be. Even if patient is not affording, I would have just told him that this is the way it has to be managed. There's no other choice. See, giving a choice which is no, I'm sorry if you get because this
No,
is
no,
the
no,
way
it's perfectly fine.
today people are managing, but I would strongly say this is the way it should be managed. This is not the right because we know that it can cause more
Cause
harm.
problems.
And the first thing which is taught to us is not to cause harm because we know because that's you. Luckily, this patient was very lucky. Nothing
just
happened.
lucky.
But definitely a giant retinal tear with such a large quadrant multiple time, and when you know that once it has failed, definitely I personally feel it's not
I
the great
agree, sir.
choice.
That's the reason. So the reason I wanted to share is
I
this.
think
There are
Harshit
two.
is now follower of our Canadian
No,
friend, no?
No, sir. What I wanted to, that's the
Yes.
reason I wanted to highlight those 2 points more specifically, sir, that the case selection and the patient, it
Absolutely
has
true.
to be important. I mean,
That is
this is something
important.
I managed,
Yes.
but the takeaway is not
Is
that you
yes,
do this.
absolutely. I think
It's
that
like,
is
it's the case selection and ensuring that the
ensuring.
IDO is
Yes.
proper. So
Yes.
I mean,
And
that's
second thing I would say that though no, there are certain things which as a physician you have to tell that this is the right thing. You cannot say that patient wants bubble, that's why I gave bubble. That should not be the case.
Rajiv, there's a guy from what is his name? Rajiv, no?
Yeah, Rajiv
Harshit.
Muni.
So
Muni.
he, I mean, he says
Can I-
any patient only
Every patient
pneumoretinopathy.
you should see
Yeah,
That's
his
what I'm
and
telling.
second,
See,
no,
we
I
have
went and
burned our
presented on.
fingers many times with that. That's the reason.
That's why I went
So
and
can I
presented
add
on
a
scleral
small-
buckling.
Can I
Yeah.
add a small historic caveat here, sir?
Please.
So pneumatic retinopexy, before it became very popular, and being attributed to Hilton, a lot of people had done it before, and Dr. Ingrid Kreisig in a paper in 1978, sorry, not 78, 1981, had, this paper or where they described usage of pneumatic retinopexy in the so-called difficult retinal detachment cases, which were non-buckleable, like GRTs and, multiple breaks and posterior breaks. And right now, what is being done is just that, the author that Dr. Natarajan sir mentioned, they're doing the exact same thing, and still they have not, improved upon the results. Their results are close to 80%, and even in 1981, they had results close to 76%. Now, the point is that whenever we choose surgery, and Dr. Ingrid Kreisig says this herself, you have to choose the surgery with the best single operation success rate, where you cannot go on doing things and, taking a risk with the patient's eye. So it is up to us to be able to counsel the patient in such a way that a sensible choice is made.
Rajiv.
Yeah.
Hello, Rajiv. Can you hear?
Yeah. One thing I'll add, that
Actually,
what you said is right, that
So-
recurrent detachment, actually, Dr. Tarun Sharma group has published in a recurrent detachment use of pneumatic retinopexy, very good results. But again, in a the case selection was most important. Yeah, please.
Yeah, Rajiv. Yeah, no, one more thing I want to tell Mohan. Dr. Jivanovic used to tell that it's a weekend surgery and the surgeon doesn't want to do the scleral buckling or a vitrectomy, so he does the pneumoretinopexy. And I think Rajiv is doing in Canada because of the insurance problem, I think, not because of the real surgical requirement.
Yeah,
But,
Mahesh,
if
you
you
wanted
look
to
at-
add.
As
Actually-
Rajiv,
and
as
people,
Rajiv Raman said, we should know what is important for the patient.
absolutely, we should know the limitations
Yeah.
of pneumoretinopexy. And
And
that's why
I think
I'm
the
glad
US
that
and
Harshit brought this video here, because we know exactly how to draw a line between pneumatic retinopexy and vitrectomy. And Mahesh, you want to say something?
Yeah. Actually, way back in 2005, me and Dr. Giridhar were going to for a state meeting at 5 o'clock. One patient with GRT came at 3 o'clock. Okay, so we didn't have the time to operate, so we gave laser, only laser. It was not folded, just a little GRT with a little folding. That remained like that for 10 years.
Yeah.
10 years.
Without laser, but that doesn't mean that I do laser for all GRTs. This 10 years that the retina remained attached, and he got a cataract surgery. Later it became detached after 10 years. So that was we just want to do something and go for the conference and come back. So this is, and when we tell the treatment, you decide which is the best for the patient and tell the patient. These cases, pneumatic retinopathy is not in my list at all. It is not in my list. So when I tell the patient this is the possible option, you can just tell. That is what I do. So anyway, nice case for a discussion, good discussion, and probably everyone has got a good message from this.
We also have Dr. Dhanashree
No,
Batra.
no, I have a, no, what Mohan, I have
Yes.
very good patients where that, okay.
I think, can we have a from Dr. Dhanashree, please?
No, we have done. I've done long time back so many pneumoretinopathies, but they're all doing very well even now. But we know the limitations.
Lady, madam, you are there?
Dhanashree, Natty's voice is breaking.
Yeah, well, I think in
That
interest
does
of
not
time, move on to the final talk.
Final talk, yes.
We'll do
Dr.
for
Krishnendu, are you
everybody.
ready now? Dr. Krishnendu?
Yeah, I have sent it to
I'm going to
Mr.
play.
Sai.
I'm going to play the video now, doctor.
Yes, I.
Sai, thanks a lot, Sai. Audio is also there?
Yes, sir. Audio is there.
Dealing with fire. Here we present a surgical case of a subretinal foreign body removal. Nil financial interest to disclose. A 32 years old male presented with dimness of vision in the right eye for the past 1 year. There was a history of blunt trauma to the eye a year back. On examination, the best corrected visual acuity of the right eye was counting fingers at 3 meters and left eye was 6.9 N6. Intraocular pressure was 12 millimeters of mercury in the right eye and 16 millimeters in the left eye. Slit lamp examination was within normal limits. Fundus examination of the right eye showed inferior retinal detachment with query siderotic changes. Left eye fundus appeared normal. Ultrasonography of the right eye suggested presence of intraocular foreign body in the pars plana region with confirmed inferior retinal detachment. No wound of entry was found in the right eye. Surgical intervention plan for the patient was vitrectomy with intraocular foreign body removal under local anesthesia. After aseptic dressing and draping, 3 25 gauge ports were made and vitrectomy started. Inferiorly, the detached retina was noted to have an yellowish tinge suggesting siderotic changes. Core vitrectomy was completed. While performing inferior base dissection, a metallic foreign body was noted stuck near the ora serrata around the 6 o'clock position. After removing vitreous around the foreign body, it suddenly slipped through an adjacent break into the subretinal space and got lodged near the inferior arcade. Perfluorocarbon liquid was then injected over the posterior pole to prevent further posterior migration of the foreign body, and vitrectomy was continued. A retinectomy was made beyond the inferior arcade to facilitate removal of the foreign body. The superotemporal sclerotomy port was enlarged and a 20 gauge magnet introduced through the superotemporal quadrant, and the foreign body was grasped from its subretinal location. It was then brought to the mid-vitreous cavity and held with another forceps. Finally, a basket forceps was used to grasp the foreign body with handshake technique and then removed through the enlarged port in the superotemporal quadrant. Fluid air exchange was performed to settle the retina. and endo laser was done to the iatrogenic posterior brake and the peripheral brakes. Silicone oil was then injected and the ports sutured with 7-0 vicryl suture. The postoperative period was majorly uneven. The best corrected visual acuity in the right eye was now 624 and N12, and the intraocular pressure was at 14 millimeters of mercury. Fundus examination revealed an attached and stable retina under the silicone oil. Thank you.
Wonderful.
Excellent video, KNI.
Worth the wait.
Very nice.
Yeah, but I was little bit confused while it gone to the subretinal space. I never expected it to happen, but it happened.
Slippage of foreign body is very common. In fact, you are dealing with any case of foreign body, especially metallic foreign body. The first thing you have to make sure is it should not slip. Slippage is very common. And you are actually lucky it didn't go on the macula.
Yeah, that is why I was in hurry in putting the LPFC.
Yeah.
Okay. I think we have Dr. Chetan Rao here with us still. Dr. Chetan, can you comment on this, please?
Yeah, so the foreign body, whatever you do, if the foreign body is really ragged and irregular, it may not budge from its position. It's just that it just rolled. It's like, stone. It can just roll, and it may stop at one of its edges. So it's okay that you put an LPFC that just helped in keeping the macula attached. It probably would not have prevented your foreign body to go. So the other thing you could have done was actually, if you made a retinotomy a little away from the arcades and introduce, or maybe just made the retina a little bullous, introduce your what do you call it? The magnet slightly away, it would have floated into that thing and it would have taken out from another area. This is a little close to the arcade. So
yeah, it was very close.
Yeah, you would have had a problem suppose that thing would have broken. I mean, the vessels would have bled. You'd have a problem. You'd have lost your foreign body anyway. So a little away, and maybe you can introduce your this thing, your magnet.
Dr. Aran.
It would have floated.
Yeah, I think what Chetan is telling is that could be one approach, but you managed it pretty well. I think at the end of the day, you could remove the forehead body, attach the retina. I think did a great job.
My only worry was I have to make a macular hole to remove the forehead body.
Yeah,
that
so
was
that was not needed. I think that is something. So
what if it has gone under the macula? What if it has gone under the macula?
Then I have to do. I have to dissect. I mean, fold the retina.
No, I think probably away from you have to. I mean,
make a
like a subretinal ceruleum removal sort of thing. You have to make a big this thing, and turn the retina, flip the retina, and remove it. No other way. We think about the worst complication.
Yes, yes.
Post-operatively, any problem was there with the siderosis, KNI?
Siderosis, no, there was no problem, but I have not removed the silicone oil yet. It's only 2 months old. So I have to see once I remove the silicone oil, then I may face problem because siderotic atrophic retina. So it might cause multiple break formation later on in future. So
ERG and IOP are the two things that can guide you. ERG and IOP.
Yeah, ERG will be subnormal. ERG is subnormal now, but
yeah. So
IOP
what you need to
now.
look for is that how is your B wave, and if the
is,
B wave reduction is more than 40%, 50%, definitely that's not reversible, and it will not. But one good thing is the progression will stop once you have removed the foreign body. So it's not like even with siderotic changes, it will not keep on increasing. But if your B wave amplitude is about 40 to 50%, definitely there is reversibility. So the changes tend to reverse.
I think Krishnendu, the ERG is subnormal now because of the silicone oil. Silicone oil is an insulator.
Correct. Absolutely correct.
it will be quite depressed right now.
Yes,
But once your
yes.
silicon removal is done, then it will the ERG will become better.
Because the other part of the retina seems to be looking good. It's only the
Yeah.
inferior one.
Yes.
So I do expect that the B wave amplitude initially ERG was done before.
No, sir. No, it was not done. I have done
So
it
that
after
can give
the
you idea
surgery.
whether it is reversible or not.
Yeah.
Any role for buckle inferiorly? This case?
Yes, if it recurs back, then I have to put a buckle definitely.
Because usually that cerebrotic area, the
Yeah.
retina is quite atrophic and thin, no?
Yeah.
Sleeve-like breaks can occur.
Yeah.
Wondering.
Yeah. Yes, sir. There is a role, but definitely at this stage, he never anticipated creating that. But later, if suppose there is anything, he will need to put a buckle there.
Thank you. Thank you very much.
Thank you,
All
everyone.
Great case and very nicely managed.
Beautiful, beautiful.
Very nicely managed, and I think we are quite on time. And
Yeah.
with once again the entire office bearers of Shankar Nethralaya Alumni Association, as well as all the presenters, panelists, and also the audience taking out time today and joining us. And this is going to be a continuous activity, so we request active participation from all of you. As Dr. Natarajan sir said, that we need to have a global presence of our alumni even for this webinar meeting. And also request each one of you to be present also on in the physical meetings which happens in second week of July every year at our alma
12th
mater.
and 13th, most probably. Yes.
Yes, sir.
Yeah, that's fine. And the next
From
week,
anyone
Manoj,
before we close down the session, and any other comments, suggestions from anyone else?
Manoj, the next meeting will be, the
Speakers,
next webinar will be on November 13th, 8 p.m.
Yes, sir.
November
Yeah.
13th.
Yes, sir.
And the topic will be most probably on UVR.
Yes, sir. Yes, sir.
Sure.
So if yeah, if
Manoj, I would like
no one has
to
any comments.
Manoj, I would like to say a few words.
Yes, sir.
First of all, I would like to thank all the panelists and Dr. Natarajan, Rajiv, Mahesh, Chetan, and of course the moderator Manoj, and all the people who have contributed to this significantly to this SN alumni webinar, or the first webinar, and all the presenters who did a fantastic job. I thought really good job. And yeah, just to reiterate the point that among all the alumni associations in our country, we are the strongest. We have got our presence not only in our country but across the world, as Natti rightly said. But I think we have to show this solidarity together. I think it's high time we do it because all other alumni are doing it. But it's high time we do it now because we have to rise, awake, and arise. So it's very important for all of us. So that's my sincere appeal to all of you.
Yes, sir. We all will be working towards it. And as I said in the beginning of the webinar, that keep one motto in mind till April 2025. We have All India Ophthalmic Society elections coming up, and we want someone from our alumni this time to be the president of All India Ophthalmological Association. And we have to work towards the election and make sure that Sir wins hands down this time. With this sincere request, I think we'd like to close down today's webinar, and we'll keep meeting you every second week. Your suggestions and your thought process are welcome to make this even better. And as rightly said, we also need more and more attendance, not only in the webinar, even at the our annual physical meeting in Chennai. Yes, sir. Okay, with this, we'd like to conclude.
Happy Diwali, safe Diwali.
Happy Diwali all. Bye-bye. Good night.
Good night. Good night.
Happy Diwali. Good night.
Happy Diwali.
Good night. Thanks a lot for everything.
Thank you. Thank you.
Thanks, Sai, Manju, for the back end. Very good. And
most welcome, Doctor.
His sign as pharmaceuticals for sponsoring this continuously for the 6 webinars they're going to sponsor us. Thank you.